Okay, so now we are officially 10:03, so we're going to go ahead and get started. I want to say thank you all. First of all, good Wednesday morning and welcome. We are glad you are here. This event is hosted by the Kentucky Safety Prevention Alignment Network, also known as KSPAN. KSPAN is a network of public and private organizations and individuals that are dedicated to promoting safety and violence throughout the Commonwealth of Kentucky. There's no cost to join, just a desire to prevent injuries. You can check us out by visiting www.safekentucky, spelled out, .org. I've also placed the link in the chat if you want to sign up as well. So again, thank you all for joining. As you can see, this is what we have outlined for today's start. Before we get started, you'll notice on the agenda that we are going to try closely to adhere to it, but that domestic violence and intimate partner violence are both used. To clarify, domestic violence can also refer to as intimate partner violence. The terms can be used interchangeably when we are referring to family violence. And I do want to make this disclaimer. If you or someone you know is experiencing domestic violence or you are unsure about your situation, please call, text, or visit any of these free confidential 24/7 helplines. And if you are in danger and it is safe, please call 911. I'm going to place these in the chat, but we have the National Domestic Violence Hotline, the Love is Respect hotline for teen dating abuse, as well as RAIN, National Sexual Assault Helpline. So hopefully you put those, and it's always great to store those in your phone in case you ever need to be a resource to someone or yourself. So first of all, let's welcome Miss Calla Jamison. Calla, you can go ahead and get you to start sharing. Calla is actually from the CDC. She is a health scientist in the Division of Violence Prevention in the National Center for Injury Prevention and Control at the Center for Disease Control and Prevention. Her focuses include evaluation, capacity building, and health equity. Calla is committed to supporting violence prevention practitioners to implement and evaluate their work. Calla is going to be talking to us about adverse childhood experiences and intimate partner violence prevention. Let us welcome Calla.
Thank you so much, Ashley. Are y'all seeing my screen in the right way, the right view?
Yes, ma'am.
Okay, perfect. Always have to check. Like Ashley said, I'm a health scientist in the Division of Violence Prevention at the CDC. Within the Division of Violence Prevention, I am in the Prevention, Practice, and Translation branch, or we just call it the program branch for short, which administers programs to prevent multiple forms of violence. And I'm calling in from Atlanta, but I am from Baltimore, Maryland. And I'm really excited to be here today to talk about ACEs and IPV. Admittedly, this is a terrible presentation title that goes against all best practices about using acronyms without spelling them out. But the CDC loves their acronyms, so I had to do it, and I'm going to get into both shortly. So as you can see here, we'll start by talking about ACEs, their impact and relationship to intimate partner violence. Then we'll get into intimate partner violence, the burden, risk factors, and prevention strategies. Okay, so adverse childhood experiences, or ACEs, are potentially traumatic events that occur in childhood. Examples include experiencing violence, abuse, or neglect, witnessing violence in the home or the community, having a family member attempt or die by suicide. It also includes aspects of the child's home environment that undermine their sense of safety, stability, and bonding, such as growing up in a household with substance use problems, mental health problems, or instability due to a caregiver or household member being incarcerated. These are just a selection of ACEs. There are many types of ACEs, and ACEs are common. 64% of American respondents report at least one type of ACE, and 17% report 4 or more. So there are lots of long-lasting impacts of ACEs, potential impacts of ACEs. The effects of ACEs can add up over time and affect a person throughout their life and have lasting impact on health, behaviors, and life potential. So children who repeatedly and chronically experience adversity can suffer from toxic stress. Toxic stress happens when the brain endures repeated stress or dangers, then releases fight or flight hormones like cortisol, and can disrupt organ, tissue, and brain development. So research indicates that toxic stress during childhood can harm the most basic levels of the nervous, endocrine, and immune system, and can even alter the physical structure of DNA. So changes to the brain from toxic stress can affect things such as attention, impulsive behavior, decision-making, learning, emotional responses, and response to stress. So essentially, over time, this limits a person's ability to process information, make decisions, interact with others, and regulate emotions. So ACEs are associated with a host of outcomes, increased risk of chronic health conditions such as heart disease and cancer, health risk behaviors like sexual risk behaviors and smoking, social outcomes such as unemployment and educational attainment, and mental health conditions and substance use disorders. The consequences of ACEs can be passed down from one generation to the next if children don't have protective factors, protective buffers like positive childhood experiences or a caring adult in their lives. So now I'll talk a bit about the relationship between ACEs and intimate partner violence. This relationship is well established. There's a known and researched link to perpetration and victimization of intimate partner violence, but we're going to focus on the relationship to perpetration. So this is also known as the intergenerational transmission of violence. And ACEs are associated with an increased risk of IPV in adolescence and in adulthood. And the link to perpetration is relatively consistent across biological sex and race and ethnicity. So ACEs are also associated with other forms of violence and suicidality. And in particular, experiencing child abuse and neglect and witnessing IPV are strong predictors of IPV perpetration. So there's lots of research about those ACEs and their relationship. More recently, there's evidence about other adversities in childhood increasing risk of IPV, like parental incarceration, divorce, and parental mental health problems, but that early exposure to violence is the most well-supported or well-researched indicator. Findings from multiple studies reveal that there is a cumulative effect of ACEs, whereby individuals' risk of IPV perpetration increases with each childhood adversity experienced. It's important to note, and I want to make sure I communicate that while this link exists, even when exposed to early life adversity, most individuals do not go on to initiate violence in their intimate relationships. So the majority do not. So there are several mechanisms that may explain the relationship between ACEs and IPV. I do just want to say that this in itself is some researchers' focus and life's work and could be its own lengthy presentation. And I'm going to greatly simplify these as I am not the type of scientist that studies these biological pathways, but I do just want to highlight them. So the first one is observational learning. So social learning theorists posit that exposure to violence in the home, in the family, increased children's risk of drawing on violent behaviors in relationships, and developing an expectation of violence or feeling that violence is necessary to end interpersonal conflicts and to maintain control. So essentially replicating behaviors that you grow up seeing. The next is disruption in social cognitive processes. So children that experience ACEs experience difficulty recognizing and responding to environmental cues as a result of having adapted to unsafe home environments. So they later perceive threats to their safety where there are none and develop behaviors for safety and survival in their youth that then become problematic later in life. So repeated exposure to stress may negatively affect the central nervous system. So this can cause structural changes to connections in the brain that are necessary for emotional regulation responses to stress, and secure attachment styles. So this may in turn cause development of unhealthy coping mechanisms. I also want to touch on some correlates of both ACEs and IPV. So these are factors, conditions, or behaviors that are outcomes of ACEs that are also associated with increased risk of IPV. So mental health challenges, particularly PTSD and depression, these are well-documented outcomes of ACEs, and research also finds that mental health problems increase risk of perpetration as well as victimization of IPV. So substance use, research has demonstrated substance use is a relatively consistent correlate of IPV in adulthood or adolescence, and ACEs increase the likelihood of drug and alcohol-related problems. And relationship dynamics. So exposure to violence in a family has been found to increase the likelihood of poor interpersonal adjustment through fears of abandonment, mistrust, and greater odds of trying to make a partner jealous. And researchers have found links between jealousy and controlling behaviors and partners' mistrust and the likelihood of engaging in IPV. Finally, financial stress or economic instability. Research has also found a link between ACEs and negative financial outcomes later in life, and financial stress and instability are understood to be a risk factor for intimate partner violence. So there are a couple of considerations to responding to ACEs with an eye toward reducing the risk of intimate partner violence. So first is treating the past and the present. So it's important to understand underlying forces in individuals' early lives that may have heightened their risk, but also the present behaviors and concurrent risk factors for those behaviors. So in addition to treating trauma experienced in early life, it's important to address what is happening right now. Additionally, an integrative approach that combines trauma-informed interventions with substance use and mental health treatment may be more successful at reducing IPV perpetration than a siloed approach of treating those individually. So now I'll get into intimate partner violence, or IPV. As Ashley mentioned, these are also referred to as domestic violence or family violence, or teen dating violence when it happens in adolescence. And at the CDC and the Division of Violence Prevention, we use intimate partner violence to broadly capture all violent behaviors between partners. So intimate partner violence encompasses physical violence, sexual violence, stalking, and psychological aggression by a current or former intimate partner. This includes spouses, boyfriend, girlfriend, dating partner, ongoing sexual partner. And it's understood that IPV starts early and continues through people's lives. So it often begins in adolescence. And as you can see in these graphics, there is a great burden of IPV. 1 in 3 women and 1 in 4 men report physical violence from an intimate partner in their lifetime. And the burden is great, and it's not shared equally across all groups. Many racial and ethnic and sexual minority groups are disproportionately affected by intimate partner violence. So violence can be prevented, and I will now talk about CDC's approach to violence prevention. So the Division of Violence Prevention emphasizes primary prevention, which means stopping violence before it occurs, stopping violence before it starts. And this is distinct from immediate responses or emergency responses to violence, which are secondary prevention, or long-term treatment for survivors, which is tertiary prevention. So all of these are important, but primary prevention is the primary focus. The CDC uses a 4-level social ecological model to better understand violence and the effects of potential prevention strategies. The model shows the interplay of factors between 4 levels of society and the range of factors that can put people at risk or protect them from experiencing or perpetrating violence. This model also suggests that in order to prevent violence, it's necessary to act across multiple levels of the model at the same time. And this approach is more likely to sustain prevention efforts over time and achieve a population level effect. So let's look at the different levels. The first level identifies biological and personal history factors like age, education, income, substance use, or history of experiencing violence. And prevention strategies at this level promote attitudes, beliefs, and behaviors that prevent violence. Specific approaches may include conflict resolution and social emotional learning. And the second level examines the close personal relationships that may increase the risk of experiencing violence as a victim or a perpetrator. So this includes a person's closest social circle, their peers, partners, and family members. And prevention strategies at this level may include parenting or family focus programs and mentoring and peer programs designed to strengthen communication, promote positive peer norms, problem-solving skills, and healthy relationships. The third level explores the settings in which social relationships occur and seeks to identify the characteristics of these settings that are associated with violence. So prevention strategies at this level focus on improving the physical and social environment in these settings. So creating safe places where people live, work, and play. So this includes organizational strategies in workplaces and schools. And strategies also seek to address the other conditions that give rise to violence in communities, such as neighborhood poverty, residential segregation, and instability, and high density of alcohol outlets. The fourth and final level looks at broad societal factors that help create a climate that either encourages or inhibits violence. These factors include social norms that support violence as an acceptable way to resolve conflicts, and other large societal factors such as health, economic, educational, and social policies. Prevention strategies at this level include efforts to promote societal norms that protect against violence, and efforts to strengthen household financial security, education and employment opportunities, and other policies that affect the structural determinants of health. So strategies at all levels are important for a comprehensive prevention plan or a comprehensive approach. But we emphasize working at those outer levels of the model because the community and societal approaches have the broadest impact. So I've talked a little bit about protective factors and risk factors. So I'm going to highlight some risk factors for intimate partner violence. So research indicates a number of factors increase risk for perpetration and victimization of IPV. And it's important to note that the different forms of violence often share the same risk factors. So many of these are also associated with child abuse, neglect, youth violence, sexual violence, and other types of violence. And this is just a selection of risk factors at the community and societal level. Harmful norms include rigid norms about masculinity and femininity, and norms that support aggression towards others, income inequality, weak health, educational, economic, and social policies or laws, neighborhood poverty, and poor neighborhood support and cohesion. And these are a selection of risk factors for IPV at the relationship and individual level of the social ecological model. These include social isolation or lack of support, economic stress, family conflict, a history of violent victimization, mental health problems and substance misuse, and lack of nonviolent problem-solving skills. So less is known about protective factors, but there are evidence-based protective factors that I've not included here, which include coordination of resources among community agencies and community support and connectedness. So now we'll get into prevention strategies and approaches. So the ones included here are approaches and strategies that are included in the Intimate Partner Violence Prevention Resource for Action, formerly known as the Technical Package, which is a compilation of programs, practices, and policies with evidence of impact on IPV victimization, perpetration, or risk factors. And they use the best available evidence at the time. Also want to mention that we're focusing on IPV, but these strategies and approaches also prevent multiple forms of violence. So this is the full list. teach safe and healthy relationship skills, engage influential adults and peers, disrupt the developmental pathways toward partner violence, create protective environments, strengthen economic support, and support survivors to increase safety and lessen harms. Today, I will be focusing on the approaches that our recipients are primarily funded to implement. So these are the ones that the Division of Violence Prevention emphasizes. They operate at the community and societal level of the social ecological model. So again, we emphasize these outer level strategies because they are most likely to have a broader impact. So the first strategy is create protective environments. These approaches work to foster a social and physical environment that improves safety, social connections, and awareness of intimate partner violence. And they seek to bolster neighborhood and community characteristics that are protective factors, such as social cohesion, collective efficacy, and positive social norms. So the first approach within the create protective environment strategy is to improve school climate and safety. School environments offer a potentially influential context that can be changed or adapted to promote prevention. So creating a school environment that enhances safety and feelings of safety, promotes healthy relationships and respectful boundaries, and reduces tolerance for violence can play an important role in reducing rates of teen dating violence. And throughout, I'm going to highlight a selection of evidence-based programs or policies within each approach. These are absolutely not the only ways to prevent violence within each focus area. I'm just highlighting a couple. So the first one is shifting boundaries. It's a program designed to reduce dating violence and harassment among students. It consists of a classroom-based curricula and school-wide component. The building level component includes school protocols to identify and respond to dating violence, and a school poster campaign to promote awareness and reporting of incidents, and importantly, a process to identify hotspots called hotspot mapping, to identify the areas in the buildings that are designated by students and staff as unsafe and develop strategies to address them and make them feel more safe. Similar to school settings, the workplace also represents an important context where safety and awareness around IPV can be addressed. So this approach is to improve organizational policies and workplace climate. These approaches foster protective environments in the workplace through the creation of organizational policies and practices that promote safety and encourage help-seeking behavior. They can facilitate positive changes in workplace climate, increasing feelings of safety, and reduce perceived tolerance of violence. So one way to do this is an IPV in the workplace training. This specific one is a computer-based training developed for employers that covers topics like defining IPV in the workplace, how IPV affects the workplace, how to support survivors, and resources for developing an IPV workplace policy. The next one is an interesting one. It's the United States Air Force Suicide Prevention Program. So it was not explicitly focused on IPV prevention. The program was developed to reduce stigma and social norms that discourage help seeking among U.S. Air Force personnel. And evaluations of the program showed significant reduction in family violence. So creating an organizational culture that encourages help seeking and increased service referrals for people in distress benefited not only individuals at risk for suicide, but those couples that were at risk for IPV. All right, and this is modify the physical and social environments of neighborhoods. I find this approach really exciting. These approaches address aspects of neighborhood settings that increase the risk for IPV, including alcohol outlet density, physical disorder and deterioration, and social disorder. So we know that exposure to neighborhood violence is a risk factor for IPV. And additionally, signs of neighborhood disorder may lead people, including potential perpetrators, to believe that consequences for IPV perpetration aren't likely. So these community level factors can be addressed by changing, enacting, or enforcing laws and regulations, improving economic stability of neighborhoods, and changing the environment to improve social interaction and strengthen community ties and social cohesion. in order to promote residents' willingness to monitor and respond to problem behavior. So the first way to do this is to modify environmental characteristics of neighborhoods through greening activities. And greening includes a range of activities such as fixing up and replacing abandoned buildings and vacant lots, removing trash, planting grass and trees in community gardens, creating parks and recreation areas, and other activities that bring residents together. So greening is intended to promote connectedness and create safe and appealing spaces for residents and businesses. And research has shown that green spaces in urban communities have been linked to higher levels of community, neighborhood collective efficacy, and reductions in violent crime. Next is alcohol-related policies. So alcohol outlet density, which is the number of locations where alcohol can be purchased, has been consistently linked to higher rates of IPV. So policies that work to reduce a community's alcohol outlet density are an example of an approach that might help reduce community rates of IPV. The second strategy is strengthening economic supports for families. So evidence suggests that poverty, financial stress, and low income can increase the risk for IPV. Studies also show that gender inequality in education, employment, and income is a risk factor for IPV. So efforts to improve financial security for families and women's education, employment, and income may reduce IPV. So improving ways to support families by providing income supplements, income generating opportunities, and decreasing the gender pay gap target these IPV risk factors directly. One way to do this is through benefit programs like TANF and SNAP. These programs can strengthen the household financial security through providing cash benefits to low-income households, which studies suggest can lead to reductions in IPV. And tax credits, so research on tax credits like the Earned Income Tax Credit and Child Tax Credit show that they can help lift families out of poverty and are associated with long-term educational and health benefits to recipients and their children. Microfinance programs provide a range of financial services and opportunities to low-income families, often with the goal of improving a community's financial health by empowering women. Lastly, comparable worth policies, also known as gender equity or equal pay policies. So many states have equal pay laws, but these laws vary in terms of their provisions, who's covered, and the remedies available to employees. So these policies can increase the economic stability of women and their families. The second approach is strengthen work-family support, and this can be done through family-friendly policies, which address several risk factors for violence, including financial stress and hardship, instability in childcare arrangements, depression, family conflict, and parental stress. So family-friendly policies promote stability and buffer against risk for multiple forms of violence. Paid and job-protected leave policies help individuals keep their jobs and maintain income and help women remain in the workforce. Research in particular suggests that access to paid maternity leave may be protective against IPV. So those are just two of the strategies that the Division of Violence Prevention promotes. And now I will briefly go over the Division of Violence Prevention programs that we administer. And I'll start by highlighting the IPV prevention program. So this is the Domestic Violence Prevention Enhancement and Leadership through Alliances, Achieving Health Equity through Addressing Disparities, or as we more simply refer to it as Delta Ahead. Delta is a 5-year program that funds 13 domestic violence prevention statewide coalitions to address intimate partner violence, social determinants of health, and health equity. So these statewide coalitions conduct state-level efforts to influence intimate partner violence risk and protective factors, and they also work with and distribute funds to community-based organizations to do work at the community level. They implement intimate partner violence prevention strategies to promote health equity at the state and community levels, and are also encouraged to partner with rural communities and indigenous communities. And there have been several iterations of Delta. Before Delta Head, there was Delta Impact, and before that, Delta Prep. And this iteration specifically is requiring recipients to conduct policy efforts to strengthen economic supports at the community and the state level. The other funded programs include the Essentials for Childhood, Preventing Adverse Childhood Experiences Through Data to Action. This funds 12 recipients, primarily state health departments, to build or improve ACE's data collection infrastructure and capacity, as well as implement ACE's prevention strategies. The Rape Prevention and Education Program is the Sexual Violence Prevention Program, and it funds state and territorial health departments in every state, as well as state, territorial, and tribal sexual assault coalitions. RPE has been around the longest, since 1994, when it was first authorized by the Violence Against Women Act. And lastly, Preventing Violence Affecting Young Lives funds 8 state and county health departments to focus on preventing youth violence, teen dating violence, and other ACEs. Recipients will also address social determinants of health, such as concentrated poverty, limited educational opportunities, and racial inequity. So those are the 4 current programs administered by the Prevention Practice and Translation Branch in the Division of Violence Prevention. And I've included some resources here. These are CDC resources, as well as some by our National Technical Assistance providers. My references, which is a tiny font, but I believe you will get these slides. And I just want to thank you so much for listening. And I think I will turn it back over to Ashley.
Thank you, Calla, for that presentation. We have a few minutes if we want to open it up to questions. I welcome folks to unmute themselves or place it in the chat, and I'd be happy to ask Calla herself. Okay, Calla, as folks are, thinking about the big questions they have to ask you, you mentioned evidence of protective factors for intimate partner violence. And 2 of those were the coordination of resources and community connectedness. And I understand there seems to be a little better coordination of resources and community connectedness when we're referring to more urban areas. So when we talk about rural areas, what are some approaches that we can help improve this coordination and these resources? I know in our state, Kentucky, a lot of this is medically underserved as well. Dental underserved, it's just underserved areas to begin with. So do you have some recommendations or resources that you could refer us to help combat those challenges in rural areas?
That is a great question, Ashley. And we get these questions from our rural recipients, and we just had a listening session with our recipients to discuss the strategies they use and the resources that they would be best supporting them. And this was facilitated by the Office of Rural Health. So I can refer back to that presentation and the Office of Rural Health and drop some resources in the chat once I'm not presenting anymore, because I don't know them off the top of my head. But I will say, we've also had questions about the greening approach and how, there are plenty of green spaces literally in rural areas, but there's still risks and high rates of violence. So I do want to emphasize that greening is not just about the literal presence of green spaces, but about community connectedness and bringing people together and creating that social cohesion. And we do have recipients that are implementing that activity in rural areas and doing it in a really interesting way. But so I can refer back to some of these resources and drop them in the chat. And Jakita, I don't know if you were referring to those protective factors that Ashley dropped in the chat, or the 2 strategies that I presented are strengthen economic support and create protective environments. So those are the two of the several strategies to prevent intimate partner violence.
Do we have any other questions? I have another question for you, Calla. So we know bind standard approaches really work to help prevent, intimate partner violence, other forms of violence and injury as well, such as green dot. And this is typically, in our state, it's middle school and high school, but predominantly high school. Tabitha or Astria, please correct me if I'm incorrect, but it's about, encouraging those bystander approaches among our youth. So what are we doing, or what are some strategies we can use to focus on the ages outside of school? So maybe 19 to 23 or 19 to 24. And these folks aren't necessarily in college or any other type of institutional academic institution. There we go. Yes, and Astria confirmed high schools in Green Dot and in communities. Congratulations, Maysville.
Yeah, that's a great question too. And one way, so yes, there are colleges and universities that are doing Green Dot, and they're also doing hotspot mapping that I talked about, which is a component of shifting boundaries. And in addition to happening on college campuses, there are neighborhoods and communities doing this hotspot mapping approach. So literally walking their neighborhoods or using maps and identifying these unsafe areas, and then developing strategies to address those areas that are identified as feeling unsafe. And beyond that, I'll just say that the strategies that I presented are those upstream approaches designed to affect entire communities. So they don't necessarily target that youth population, but rather the whole community. So I would reiterate that those are really the ones that we're emphasizing because they have a population or community level effect.
Thank you for that.
I had a question, more a comment and a question. In Kentucky, and I believe in also Ohio, we have the Purple Star program for providing support to military connected youth. And I guess my question is, have you heard of that, and any support or evidence that you've been able to, that you know of supporting that program?
I don't know it, but I will definitely look into it. What was it called?
It's Purple Star program, and it is being implemented here in Kentucky. It's in the high schools. We right now are close to 100 schools in Kentucky that have implemented the Purple Star program.
And I believe Ohio is where it originated.
That was my understanding too.
Okay, I'm not familiar, but I will look into that.
Okay, thank you.
Okay, and then Astria Howard, she is the director at KSAP. She's not the director, but Astria, please unmute yourself and introduce yourself. But she's a great partner. I just thought it'd be a great time to just advertise for Green Dot Community and let her talk to you all.
Yeah, thanks. And Calla and I have met through the RPE program before. KSAP is an RPE recipient, but through KSAP, which is this Kentucky's Sexual Violence Coalition, we fund our rape crisis centers across the state to do prevention education work. So we do a middle school program that's a Kentucky specific adaptation of shifting boundaries, which Calla was mentioning earlier. So we do that in middle schools. We do Green Dot bystander intervention in high schools and in communities. And we also do hotspot mapping in high schools and communities, and social norms programming meant to shift kind of those broader societal norms that make it less likely for people to intervene in problematic behaviors. So that work is happening all across Kentucky, and if you're interested in learning more about it, I'll drop the KSAP website in the chat, and you can always reach out to me with questions. But yeah, it's a great point to connect the things that Calla was just talking about with things that are already happening in Kentucky. So thanks.
Thank you very much for that. We also have a question here, or a comment followed by a question. Ruth mentions predators in the churches, including inappropriate touching, comments, as well as other gestures. They can trigger depression, anxiety, and suicide among folks. Where do these folks go for help? So this is it sounds more of about a faith-based. What do we do when we're inside our faith-based communities, and how do we go about preventing this and intervening?
Yeah, that's a great question. For survivors of violence, I would recommend going those sort of traditional routes. So victims, advocates, associations, and mental health treatment. But I'm less familiar with the response side. But I do think it's really, really important for these strategies to be partnering with faith-based communities and incorporating them into their community-based and community-wide approaches, because I do think they can be left out or treated in their own separate entity. And I think it's important to involve them in the strategies and approaches that I named.
Thank you. And Estrella placed in there a link to the rape crisis centers that are local to our state in Kentucky. If you're not Kentucky, we encourage you to reach out to yours as well. You should probably be able to find that through a Google, Bing, or whatever your browser search is. I also place in here a CDC train. Calla, you mentioned NIOSH offers a workplace violence training for nurses that can help, intervene and prevent ACEs and any types of violence. But if you go on this and go to CDC train, you can Google. I did a quick one on intimate partner violence and found quite a few. So it's a good resource for folks as well. And then Beth Workman, she placed in here, this is Kentucky specific as well, Zero V, which is formerly our Kentucky Coalition Against Domestic Violence. She placed a link in there to all our shelters and programs within the state as well.
Hi, I have a quick question. So, Callie, you mentioned the the push to change policies revolving around facilities that like sell alcohol, like bars, liquor stores, and things of that sort. So, is that based on like specific demographics? Because, intimate partner violence, as you have been stating, or domestic violence, could increase based off if the person is intoxicated or things of that sort. But are you saying specific areas should be cleansed of like liquor stores or the selling of alcohol, or is that just in general? So is it based off like demography, or was that a general statement?
That's a great question. I think the research suggests that just the presence of many, like the density of alcohol outlets, so places that sell alcohol, so bars and liquor stores, are associated with a community increase in IPV. So I'm not sure about if it's been down to the granular level of demographics, but I think that's a really good question. But it's not, and I do understand that we're not saying that a whole neighborhood needs to just eradicate all of the alcohol selling businesses in their neighborhood, because we also know that some neighborhood establishments can also foster connectedness and social connectedness, so it's kind of complicated. But just that the sheer presence and amount of alcohol selling establishments can be associated with increases in multiple forms of violence, not just IPV.
Prada, does that answer your question?
Yes, it does. So what, because I don't know, I get interested a lot with the built environment and how it contributes to, like you said, any really source of violence. So it's more so of what is the intent kind of behind the selling of alcohol. But because what you were saying, like some places do utilize like bars for social events, social gatherings. Most do. But it really just depends on the turnout. I don't really know how to explain it because some establishments that, sell liquor, they don't really experience violence. But then you have others, depending on really, I guess, the crowd, that where it can result into a violent act occurring depending on the situation. But I've always have just been interested on how to mitigate that without taking away socialization from the communities. But yeah, thank you.
Yeah, I think that's a great point, and don't have the answer for that nuanced question, which I think is a great one. And additionally, there's also opportunities to implement violence prevention strategies in bars and bars and restaurants and places that sell alcohol. And so I think it's a great question of how to mitigate violence and those acts that are linked to intoxication and the presence of alcohol while still fostering social connection. And of course, nothing happens in a vacuum. So there's also many other community factors involved. But thanks for your question.
Yes, thank you.